Good evening. My name is Natalia Fedorczak, and I am a student project manager at the Clark Forum for Contemporary Issues at Dickinson College. Before we begin, I would like to take a moment to acknowledge that Dickinson College is on the unceded lands of the Susquehannock Nation. We acknowledge the many indigenous peoples that lived with these lands, as well as the thousands of indigenous children forced into the Carlisle Indian Industrial School beginning in 1879 as part of a federal cultural eradication effort. On behalf of the Clark Forum, Dickinson College, the Department of Chemistry, the Department of Psychology, and the Pre-Health Program, I would like to welcome you to tonight's event, Psychedelic-Assisted Psychotherapy, a promising intervention mental health treatment. My experiences suffering with a chronic illness have shown to me the true degree of which the United States healthcare system is ill-equipped to deal with difficult, long-term, treatment-resistant conditions. For many Americans suffering with a treatment-resistant condition, the U.S. healthcare system can be dismissive and isolating, with unreliable treatment options that focus on increasing the quality of life through therapeutic means rather than curing the root of the issue. Unpredictable standards of care and limited options have contributed to a system that has failed many people nationwide. Today, preclinical and clinical biomedical research works to challenge this system by exploring new realms of treatment in the hopes of finding an alternative method of care. For some labs, this includes psychedelics. I would also like to highlight the fact that tonight's program was student-initiated. At the beginning of each semester, the Clark Forum student project managers proposed 2 programs that we developed for the next semester. After reflecting on my experiences and struggles with chronic illness and its treatment-resistant effects, I proposed tonight's event. The work that Dr. Davis does to uncover alternative treatments for conditions previously labeled as untreatable or treatment-resistant has a direct impact on my life and the lives of others like me who have been failed and overlooked by the American medical system. This event and conversations like it are one essential step in destigmatizing alternative medical treatments, which may be a key to improving quality of life for millions of people across the world. Today, Dr. Alan Davis will discuss their work using psychedelic-assisted therapies and alternative treatments to improve mental illness pathologies. They will analyze the literature available which supports the study of psychedelic-assisted psychotherapies, as well as explore the potential medical effects of psychedelics. Moreover, Dr. Davis aims to offer a foundational understanding of psychedelic research moving forward. Their lab has published more than 80 scientific articles in peer-reviewed journals, and they are piloting a study of the first human trial for psilocybin-based PTSD treatment. Dr. Davis is the director of the Center for Psychedelic Drug Research and Education, as well as an assistant professor of social work and psychiatry at The Ohio State University. As a clinical psychologist, Dr. Davis has extensive clinical and preclinical research experience on mental illness pathologies and psychedelics. Dr. Davis has held appointments on several boards and committees for research funding, journal editorship, and grant reviewing, including a position on the editorial board for the Journal of Psychopharmacology. They have also won numerous awards for research and presentation excellence throughout their career, including the University of Maryland School of Medicine's award for an outstanding research presentation. Dr. Davis has given numerous presentations of their research at conferences and symposiums worldwide. There will be a question and answer session immediately following the program, so please hold all questions until that time. The Clark Forum welcomes differences of opinion expressed politely, thoughtfully, and succinctly. Disruptive behavior or harassment of the speakers, members of the Dickinson community, or audience members will not be tolerated. As a show of respect for our speakers and everyone in attendance, please stay until the end of the program, including the question and answer session. At this time, I ask you please silence all cell phones and other electronic devices. In the event of an emergency, please know that accessible exits are located on the west side of the building. And now, please join me in welcoming our guest, Dr. Alan Davis.
Thank you so much for the kind introduction. I've been having a really weird metaphysical experience in life lately where I hear someone giving a biography of myself and I'm like, I don't know who that person is. I grew up in a family where my parents both struggled with mental health problems, and I lived in a community where I didn't really fit in, and as part of my own queer identity, really struggled with my own challenges with mental health. And so sometimes when I think back to that version of me, the version that was described seems like this whole other life. But that version of me is what guided me to be doing the work that I'm doing right now, and not only in helping veteran communities, but also in working with people who are struggling with a variety of different challenges and who currently, like was mentioned, aren't having their needs met by our current system. Here's my fun little pointer so I can move around. I'm gonna talk quite extensively about our depression trial, and I hope that through talking about that study that I'm able to explain a little bit about what this therapy looks like and what we're hoping is coming in the not too distant future for people suffering with different problems. I have to mention that the work that I'm gonna talk about tonight is funded by a variety of folks, including private foundations, nonprofits, and private philanthropists. We also have funding through the Center for Psychedelic Drug Research and Education, also funded by private donors. What you'll notice is that there's no federal funding. The federal government has, up until recently, not been willing to fund these kinds of projects. That has changed in the last year, which is really exciting. So we're hoping that more federal funding will really swing open those doors. Oh, I'm also on nonprofit boards as well. So I probably don't have to convince people in this room that there's quite a bit of attention that has come out recently, especially over the last 2 to 3 years, on the topic of psychedelic therapy. There has been a number of books published, one of the most famous being Michael Pollan's How to Change Your Mind, talking about not only their own psychedelic experiences, but also outlining the research and the people involved in that research over the last 25 years. And of course, in the last 2 years alone, there have been at least 4 new research centers started. I think our current count is that there's probably about 12 in the United States, either formal research centers or burgeoning programs of inquiry, not to mention ones in Europe and other places. So this is something that is growing at an exponential rate, and that's both exciting and, for those of us who are in these places, also a little bit daunting and terrifying, because there's a lot of interest, and where the interest is means there's also a lot of demand. And so part of the push and pull that we have is wanting to make sure that we're doing good research, and which often takes time and does not necessarily move at the pace that the need is for this type of treatment. So we're hoping to do it as fast as possible and see where that takes us. The substances that I'm going to talk about today, I'm going to talk specifically about psilocybin quite a bit, but psilocybin is part of a broad group of substances. Some of them are considered classic psychedelics, things like psilocybin, LSD, and 5-MeO-DMT, or any dimethyltryptamine-based substance. There are also other substances that are considered as part of this group that are not necessarily a classic psychedelic, but have a mix of psychedelic and non-psychedelic effects. So MDMA being one that is broadly considered a psychedelic, but also has stimulating effects. There are also some like iboga and mescaline that, again, have some features of classic psychedelics, but also have some unique properties. So when I'm referring to psychedelics as a broad group, I'm talking about these types of molecules, all of which can produce some overlapping effects that are described from a variety of different perspectives. In the research setting, we describe these 3 effects predominantly as the ones that seem to be brought about most reliably. So the mystical effect, the insight effects, and the challenging effects. There are, of course, in my opinion, a whole variety of different things that are happening both at the perceptual level, what people can tell is happening, and also, of course, at the subperceptual level biologically that might also be helping us to understand what might be helpful with using these substances. But across all of them, we see that these experiences are seemingly and quantitatively and qualitatively related to the therapeutic outcome that people are describing. So things like improved mental health, improved connection to values, and improved relationships. Of course, we're seeing this in clinical trials. We're also seeing this in research in the natural environment. We are doing studies that are helping to better understand the epidemiology across the broad population of people using these substances. And across all of these different methods, we're seeing a pattern emerge that both, whether it's in a structured setting or on your own, that these experiences seem to have the possibility to occasion meaningful outcomes. That's not necessarily a guarantee in either of these settings, and I'll talk a little bit about why that is in today's talk. And there are, of course, a variety of differences with these substances as well. Their duration can be quite different. So with LSD, we're talking anywhere between 10 to 14 hours. With psilocybin, it's typically in the 4 to 6 hour range. Something like 5-MeO-DMT, if it's smoked, it's 20 minutes. If it's injected, which is actually the way that we're planning on looking at it in the clinical trial landscape, it's about 40 minutes. So very quick, very short, very powerful substances. And also they vary based on their route of administration. So smoking them obviously can, for the ones that are able to be smoked, typically the onset is very fast, very quick, can be very challenging and difficult for some people, as opposed to psilocybin, which is orally ingested and takes about 40 minutes for the effects to start to come on. But across these different substances and these different routes of administration, we also see that people are reporting in all of these different settings that these studies have happened, that these experiences are contributing to enduring changes across a variety of different features of their life, whether that is improvements in their relationships, improvements in their mood, their behavior, a new appreciation for life, understanding maybe their purpose, understanding the meaning of their life, of course, spiritual improvements, and some of the ones that aren't listed here, which we're looking into a little bit more now, are a new understanding of death and the dying process, and a better appreciation for one's connection to nature and their connection to the environment, which people are reporting pretty strong, enduring improvements, sometimes up to years and decades after they had a psychedelic experience. So, across these different things, it makes sense that for people who are struggling with mental health problems, why this could improve their life, right? That it could potentially help them. So I'm going to dig in a little bit to the 3 types of experiences that, again, are not the only things that are going on when someone is administered a psychedelic, but these are the ones that are most often talked about. One of the reasons why they're most often talked about is because these were the ones that we have measurement tools for. And so the mystical experience, I don't think, is actually the best or the only thing that is helping us understand why psychedelics are potentially helpful, but it is the one that has a measure that was designed for it earliest. And so it's been used in all of the studies over the last 20 years. And so when we're talking about the mystical experience, what I'm referring to are these deeply positive experiences of euphoria and self-transcendence that often people will feel as though they are connected to something outside of themselves. And whether that means that it's connected to the universe, connected to humanity, for some people that connection is to a spiritual being or a higher power. For some, that's God. Whatever the connection is, it is some connection that is outside of their usual sense of their place in the universe or their place in the world. And not surprisingly, that type of experience is often described as ineffable or incredibly difficult to put into words. A lot of people will describe it more from a emotional place, and some people, frankly, will try not to describe it at all because it's too difficult to kind of wrap around in a linguistic way. But this measure of mystical experiences has been shown across a variety of studies to be related to the antidepressant effect of psychedelics or the anti-anxiety effect of psychedelics, which makes sense to me, right? If I felt more connected to others, felt connected to my purpose or my values in life, perhaps felt connected in a new way to a spiritual experience, we know that those things just from general life can help boost mood, right? To feel connected and valued with things around you. We've also, though, as a result of doing a lot of administrations of psychedelics, specifically at Johns Hopkins, where we work on lots of different clinical studies and also studies with healthy humans, we've noticed over, at this point, 700 administrations of psilocybin, that one of the predominant features, other than mystical experiences, are experiences of new realizations or a new awareness or understanding that has kind of come about during the psychedelic experience. We call this like a psychological insight, that this realization or awareness might pertain to anything going on in someone's life. It could be a new understanding about their job, or a new appreciation for a relationship in their life that is meaningful to them. Not surprisingly, for people with mental health problems, sometimes these insights are about the nature of their mental health problems. It might be for someone with a traumatic history, these insights could be about understanding that trauma from a different perspective, perhaps seeing it differently or thinking about it differently in a way that maybe they weren't able to appreciate prior to the experience. So across all of these different areas, these new insights and understandings then can be used after the treatment as something to help guide how someone wants to move forward. And not surprisingly, when these experiences happen at the same time, for example, a mystical experience, that can in and of itself be insightful, right? We've had a number of people who went into a psilocybin session as an atheist and didn't come out of the psilocybin session remaining an atheist. And that, for some people, that insight in and of itself was actually quite challenging and difficult, because it messed with their entire worldview of what they thought, all this was. Which brings me to the challenging experience. So for some, these insights, these mystical experiences can be quite difficult. It can be difficult to be confronted with your understanding of who you are in the world and what the world might be. But also, experiences can be happening at the physical level. People will feel shakes and tinges and tickles, everything from these more benign physical experiences to ones that are very much emotional and confusing and difficult. We've had some people who will experience waves of energy through their body and have new ability to sense into places in their body that maybe they were dissociated from prior to that. And so these new, unusual, odd sensations that people might be having are pretty frequent in these sessions. Probably not surprisingly, because in the clinical trial setting, we are putting eye shades on individuals. We have them listening to music. They're lying down. So we're really helping to encourage people to have an inner experience, because we think potentially that that's where some of the healing might exist for people. But it also, for some, brings them deeper into their physical presence, which can be unusual for people who might not have that sense of connection to their bodies. Of course, sometimes these can be visual experiences. Psychedelics do for most, but not all, people bring about visual experiences that range from very dynamic and immersive. People will report feeling as though they're immersed in a completely separate world or universe, or they will have flashes of colors and geometric patterns. Sometimes this is pleasurable and pleasant and enjoyable. For some people, this is difficult and challenging, and so we kind of incorporate it here as a way to understand for them to what extent those visions and visuals were challenging and difficult. And of course, an extension of that physical challenge can just be benign or even pleasurable somatic experiences. So things from just, again, an enhanced understanding and connection to one's physical experience. Or for some people, it's actually a numbness of their body, just feeling actually like they might not even feel like they're in their body and completely transcended outside of their usual physical sense of themselves, to people who might feel an immense amount of anxiety and tension during the psychedelic experience. So one term that we've been using to try to understand what these experiences might be for people is this term that I wish we had coined, but we didn't. This is a term, quantum change, that was actually coined outside of psychedelic research by someone involved in the development of other interventions, notably motivational interviewing. And so Bill Miller and his colleagues were actually exploring this topic of quantum change as it related to spontaneous shifts and changes that people would have. And in particular, they were interested in substance use and how people who were struggling with substance use disorders sometimes would have these very challenging moments where a combination of new insight and potentially spiritual moment or epiphany would happen, and that would change their trajectory, right? So sometimes this is referred to as like a rock bottom moment. And he wrote a book actually called Quantum Change, where he detailed the varieties of these different types of experiences, which when I read it, I said, this kind of sounds like for some people with psychedelics that they are kind of similar, that they're having these shifts that seem to be brought about by the combination of mystical and insight experiences. So that led us to include this kind of thought as we were designing our depression trial that we completed and published a few years ago. And we've now also extended that exploration of quantum change into trying to understand how the challenging effects fit into that. For example, challenge used to be referred to as a bad trip. And we have methodically tried to change the language around that, because more and more what we've realized is for a psychedelic experience to actually be bad and destabilizing is quite a rare experience. But there are a lot of people who talk about having these other challenges that can be quite therapeutic. For example, someone with trauma or depression might have been confronted in their psychedelic experience with the anxiety of a realization of the function of that trauma in their life. And that could be very emotional and very difficult, but actually can be very therapeutic. And we know from other types of treatments that being able to approach those memories and feelings in a safe, supportive environment is one of the things that helps people even outside of psychedelic therapy. So these challenges aren't necessarily something that we want to take away from the experience because of this potential for benefit. I should probably mention a couple more things before I move on. So this trial was embedded within these questions of trying to understand what are the acute effects of psilocybin, how might those effects either have an antidepressant quality or be affecting people with depression in other ways. So we conducted a randomized waitlist controlled study, meaning that half of the people who were enrolled in the study were randomized to an immediate treatment where they started right away, and the other half had to wait 8 weeks before they could start the treatment in order to control for just the natural shifts and changes of depression over time. We had 24 people in this study, and we also continued to follow up with them up to 12 months after the treatment was completed. What you see on this screen is our flow of the diagram of the treatment and what that looked like for people. So on the top line, you see that after people enrolled, they entered into what we call the preparation therapy phase. And in that phase, people receive 8 hours of psychotherapy with 2 trained professionals, at least one of which at the time had to be an MD or a PhD licensed clinician. The second person could be a master's level clinician or a clinician in training. So we had students also serving in that capacity. That's actually changed some now. In the current trials that are underway, the FDA has laxed some of their requirement for that lead clinician role. So it's no longer that it has to be an MD or PhD. It can now also be a licensed social worker or any other independently licensed clinician at the master's level as well. But they entered into this therapy where we would spend those initial sessions developing trust, getting to know the person, helping them to get to know us and get to know the environment. So those sessions are conducted in the same room where we're going to administer the psilocybin. We want people to feel as connected and as safe as possible before we give them a high dose of a psychedelic drug. And we spend the latter half of that 8 hours helping to prepare them for the types of effects that they might have. We talk about the mystical, we talk about the insight, the challenging, the somatic. We go through different strategies and skills that they might incorporate as they are having these experiences in case those experiences become distressing or concerning to them. For example, sometimes when people have very immersive visual experiences, those can be scary, and they can, for some people, they are surprised surprised by what shows up in those visions. As an example, we've had people who, will say like, I'm going to be okay as long as spiders don't show up because I am terrified of spiders. And of course, what we know from just like cognitive science is that the more you tell your brain you don't want to think of something, the more likely it is that you're going to think of that. So we first tell them like, okay, well, we need to practice now what's going to happen when those spiders show up, because I'm pretty sure that I can bet they're going to come up at some point. And sure enough, they usually do in some capacity. And so we try to help people recognize like, okay, when the spider shows up, what are you going to do? What are you going to say? How are you going to deal with it? The approach we usually try to encourage is curiosity. So if the spider shows up, we want you to do your best to practice like being curious and open to what this creature is. And so we'll even kind of work through like a visualization of like thinking about the spider and kind of thinking about it, and like looking into its eyes and like asking like, oh, like, nice to meet you, spider. Like, why are you here today? Like, what are you here to teach me? So we try to help them, think about it from a different way than they would normally interact with this thing that they're scared of. And we do this with a variety of different strategies. Another popular one that we use is a mantra: trust, let go, be open. And really that's for moments where people might be feeling anxiety or paranoia, where they might be concerned about, the fact that things are different and shifting and changing in their minds and their bodies, and they might not feel confident that that's okay, that they're going to come back, at the end of that experience. And so we try to help them practice this mantra of trust, let go, be open, so that in the moment, if they're scared, they can remind themselves, or we can help remind them, to trust, let go, be open, be curious, go into this experience. It's going to be okay. Don't forget, you're in a research study. We know this is safe. You're going to be fine. You're going to come back at the end of the day. We use a metaphor of a boomerang, and we'll remind them during the session, don't forget the boomerang. Like, no matter how far out it goes, it always comes back. Like, the things that might help people remember that it's going to be okay. And so far, in the clinical trial setting at least, that's true. Not always true outside of clinical trial settings, but at least with the safety of what we provide there, it's okay. They get 2 doses of the psychedelic, specifically here synthetic psilocybin. In the first session, it was 20 milligrams per 70 kilograms of body weight, which is about the equivalent of 2 to 3 grams of dried mushrooms. And in the second session, we had the option to go up to a higher dose, and that was 30 milligrams per 70 kilograms of body weight, which is about 4 to 4.5 grams of dried mushrooms. That was an option based on both what the individual wanted and what the clinicians thought were best for the person. Everybody went up to the higher dose in this study. Everybody wanted to go up to the higher dose, and all the clinicians also agreed to that, with the exception of one person who I'll describe in a moment when I talk about our study flow. That person actually ended up dropping out, and I'll explain why in a minute. So 2 doses of psilocybin. We have therapy in between those doses. They're separated by about 2 weeks. And then after the second dose, we have therapy and then our follow-up assessments up to a year later. The waitlist condition did all of the same things. They just had to wait 8 weeks before they started. What you see on this screen is our study flow. So to get to that sample of 24 people, we had to start with a sample of 870 people who screened for this study. Now, I like to point this out in part because it's good to know that these studies are highly selective, but it's also a big limitation of this research, right? That the studies are bound to actually restrict access far more than they can be inclusive of people's enrollment. The biggest reason why people are excluded in this study was actually because of geographical issues. They just live too far away from our study site to actually engage in an outpatient treatment. But for the variety of other folks that weren't able to be included, for some people it was because they had a variety of other different mental health concerns, and depression was not the primary one, which was unfortunately wouldn't work for us. And if they had too much of an intensity or severity of other issues that were concerning, like suicidal behaviors or potential risk involved in either because they had their own predisposition or had a family history predisposition for psychotic disorders or other psychotic experiences, then they were also excluded. So that would be like people with bipolar disorder or schizophrenia. And then lastly, one of the other big rule outs for this study was actually we did an fMRI task with the people in this study. So they had to also meet the requirements of that neuroimaging, and they had to be willing to do the neuroimaging, which for some people was not something that they wanted to do. And also, interestingly, people who had had any type of like head injury, people who were left-handed, because all of our tasks were right-handed, so some kind of interesting exclusion there. But we got to 27 people who were enrolled in the study. 3 of those people dropped out. The person I mentioned on the last slide who had a session was the only person who dropped out after receiving psilocybin, and the other 2 dropped out before receiving psilocybin, in part because they were like, I don't think this is for me. Like after going through talking about all of the experiences and the potential possibilities, it was not something they were willing to do. The other person who had the first session and decided not to have psilocybin again, which was their decision, was in part because their session was so difficult for them. It involved a lot of anxiety, a lot of paranoia, a lot of mental and physical challenges. And yet, the next day, when they came into their first therapy session after the session, their depression was lifted. And they said, I don't know whether, I'm feeling really good today. I don't know whether I want to do another session. And we said, okay, that's fine. But come in next week, because we'll decide next week before, you make a commitment to that decision. So they came in the next week and they said, my depression's been gone all week. I literally have had no depression for the first time in my life. And also that session was really shitty and I really don't want to do that again. So I'm just not going to do that. And we said, great, no problem. We are happy to support that. We actually kept them in the follow-ups therapeutically, even though we didn't continue them in the study. So we saw them all the way up to a year after the treatment, and their depression was gone the entire time. It never came back, at least up to a year later, which was pretty remarkable. What was interesting is around the 6-month mark, they came in for an appointment and said, I think I might want some more psilocybin. I think there might be something else there to explore. And we said, well, it's not exactly how clinical trials work. Maybe there's a different study for you now, but yeah, we couldn't do that. So our folks in this study were primarily people of middle age, which when I looked at the number 39 years old, and I was like, oh, I'm 43. I guess I'm middle-aged now. But they were primarily middle-aged. We had quite a few females in the study, which was nice to have some sexual diversity. But we did not have very much race or ethnic diversity in the study, which, of course, is not too surprising because clinical trials struggle with this in general. And psychedelic studies in particular. But we did have quite a bit of folks who had very long-term history of depression. So these folks were not people who were, generally speaking, new to depression. They had been living with their current depressive episode for on average at least 2 years. And most of them had been living with major depressive disorder for decades and had tried many different medications, had tried psychotherapy, and all had either minimal or no effect on their functioning. And when they entered into that preparation phase, which I've talked a little bit about this already, so I'm not going to spend too much time with it, the primary thing that we were doing is building that trust and rapport. And we think that that trust and rapport is not only helpful for the session itself, but in part to create a setting and an environment where they feel as though they can go deeply into these experiences. We're putting people into an altered state of consciousness with these substances that for some can be one of the most difficult and yet also insightful experiences and spiritual experiences of their entire life. And it's both a privilege and an honor for those of us clinicians in the room to witness these types of experiences, but it can also be something that we want to make sure we're facilitating the possibility that they're able to go into those types of experiences and know that they can trust that we're there for them, that we're not going to judge them, that it's going to be okay. The last thing that I hadn't mentioned yet is that we do spend time just talking about the logistics of the day. We want them to know, what time they're arriving for the session, how the dose is going to be given, who all is they're going to come into contact with that day. We want to make sure that they've met the medical provider in case they have to show up for an emergency. We want them to know all of the particulars and answer any questions that they have. Oh, the important one, sorry, on the bottom is is discussing the role of touch and consent. So this is a critical piece of that preparation phase because we want people to know that when they're in this altered state, that their ability to verbalize things like their consent to have things done to them, their ability to withdraw consent for things, it might be impaired. And so we actually practice with people after we establish what they will consent to. We actually practice what it looks like to both consent and withdraw consent without using language. For most people, that looks like either shaking their head or just like moving their hand away. What we know is that for some people who need some psychological support during these sessions, that just a simple act of like holding their hand or putting your hand on their arm can be quite stabilizing, that it can help kind of reassure them that they're not alone. But again, you're putting your hand on someone else's body when they're in an altered state of consciousness. So we actually practice them like pulling their hand away gently, and we practice that so they know that it's okay, that we're not going to be upset, it's not about us, that we want them to have control over what's happening in those moments as to the extent that they are able to facilitate that control. So talking about that ahead of time is absolutely critical. This is a picture of what the typical setup looks like that I've described. This is our old session room at Hopkins where many, many sessions had occurred. And now they have like 4 session rooms because it's gotten much bigger than what one room could handle. But this is like the default posturing for the day. So we tell people that you're going to be listening to music. That music will be playing in the room. It'll also be playing over headphones. We have the couch made up like a bed. You see the 2 therapist guides here next to this person. And this would be an example of kind of like what things look like when everything is just kind of fine, right? Well, I'll just tell you, things are not always just fine in these sessions. So this is what it kind of looks like some of the time when things are going smoothly and easy. But they can also be very different than what this looks like. Some people will be very like physical. They'll want to move their arms. They'll want to move their legs. They'll throw the blanket off. The eye shades will come flying off. They'll want to be rocking on the couch. They might want to stand up and like look at all the things that they're seeing in the room that look so different in that moment. The one thing that we tell people ahead of time is that we also want to make sure that they're safe. We want to make sure that they're not going to hurt themselves. So we do ask them to, if they can, remember to stay on the couch. Don't get off the couch without our help. And so we're right there to help them if they need that. If they want to go look at some of the art on the wall, if they need to use the bathroom, we'll come and help them just to provide some physical scaffolding in case they trip or fall. But on the couch, they can do whatever they want, with one exception, which is sexual acts. So we do have one boundary there that we talk about ahead of time, just in case erotic things come up during the session, that they know that we want you to feel those things if it's important for you to feel them, but we don't want you to act on those things. So no taking off your clothes, no other kinds of sexual things. Not a very common thing to come up, but it has come up a couple of times. And then our role during that time is to be a safe, supportive person for that individual. So we're not necessarily doing therapy during the session. In fact, therapy would actually be counterproductive, we think, to what they actually might get benefit out of that day, in part because therapy usually, for most people, involves cognitive processes, right? We're thinking about our thoughts, we're thinking about our emotions, we're talking about how we are intellectualizing our experiences to maybe understand them better. But with psilocybin, we don't necessarily want to do that. We want people to experience these things in a different way. We want you to dive into your bodies and your thoughts and your emotions and explore what might be different about that experience under the effect of psilocybin. So we're not trying to do therapy. We are checking in from time to time to make sure they're okay if they need anything. We are observing them and keeping track of behaviors that we might see. We are monitoring their blood pressure and their heart rate. We are there in case they need us. But other than that, it's a non-directive day. We're not telling them what to do unless they need our support, unless we need to remind them to practice some of those skills from the preparation phase. And then, of course, if there are challenging experiences, we do have an approach of trying to help either remind them of how to deal with it. We might encourage them to, we might turn the music down, lower, so they're not maybe so overwhelmed by stimuli. We might remind them of our basic approach, some of those mantras, the supportive touch, if that was consented to, and if it seems helpful. And then maybe some guided meditation or breath work to kind of help remind people, like, don't worry, you're here, take some deep breaths, you're here in your body, it's okay. And then in the therapy that happens the next day and in the weeks and months after, what we call integration work is the process of taking all of those experiences that happen and trying to integrate these new meanings, these new insights into your day-to-day life. So that can be quite behavioral for some people. They might have had a realization that they wanted to engage in health activities differently. Maybe they want to eat differently. Maybe they want to exercise. They want to keep connected to this body experience that was new for them. They also might be relational. People will come out of these experiences and say, yeah, I'm going to divorce my husband. This relationship isn't working for me anymore. And we usually say, like, maybe don't do that today. Like, maybe wait a little bit before making that decision. But we have had several divorces that have happened during that year follow-up. People just realizing that, like, part of the reason why they're having mental health problems is because they're in a situation that is not conducive to mental well-being. And so relationship changes, job changes are some of those things that we deal with in this integration phase. All right, so that was a lot of talking to get to our main finding of this study. The main finding, what you see here, is our comparison of depression scores between those who were in the waitlist condition while they were waiting for the treatment and those who had the treatment right away. So the bottom line with the orange squares are the depression ratings from blinded clinicians who were not otherwise involved in any of their treatment and actually never saw them. They talked with them on the phone to do these depression assessments. And the top line are the people who were waiting. So we saw that there was a significant drop in depression scores from baseline to 1 week after the second psilocybin session, and that remained low up to 4 weeks later, compared to the group who hadn't received the treatment yet, and there was no change in their depression during that waiting period. When we combine both of those groups and we look at everyone after they've had the treatment, we saw the same thing, which is everyone across the study experienced a drop in depression at some level, although some more than others, and that remained low up to 4 weeks later. This was both statistically significant, but also about 2 to 4 times in magnitude of other treatments that are currently available for depression. So when we compare this data to the studies that were used to approve SSRIs, it was about 2.5 times stronger of an effect compared to those studies. This is a self-report measure of depression, so we also asked them to fill out their own reports of their symptoms starting 1 day after the first exposure to psilocybin and then periodically through that whole time. And what we see is that actually it was a pretty big drop right after the first psilocybin session. And for most people, that kind of stayed low the entire time. For some, though, they experienced a little bit of benefit after that first session, and then it dropped further after the second session. In terms of response and remission, so these are terms that we use in clinical trials to talk about how effective the treatments were. Response is what is a clinically meaningful response, which for this study was defined as at least a 50% drop in the severity of your depression symptoms. And we saw that at 1 week and 4 weeks after the treatment, almost 3/4 of the people had this greater than 50% reduction in their depression symptoms. And interestingly, half of them were in complete remission of depression. What I would like to point out about that statement, because it is very powerful, is that half were in remission. That's amazing. But that also meant that half were not in remission. So this is not a magic bullet. This is not going to fix mental health, and this is not going to be a cure-all for everyone. This works for a very small sample of people who were drawn from a very big pool of people who were not otherwise eligible. And for even in this highly selective sample, only half were in remission. Now, did those other half of people need maybe a 3rd dose of psilocybin? Did they need a little bit more therapy? Possibly. So it's possible that if we extended their treatment, maybe they would have been in remission. What was really fascinating for us was that the people who were not in remission, often when we were working with them clinically, there was, of course, disappointment, right? They had usually been through lots of other treatments. They had so much hope and so much expectation that this treatment was maybe going to be the thing that helped them because they had read Michael Pollan's book or they had seen something on the news. And what was interesting is that there was this disappointment, but at the same time, they said that something had changed, that for many of them, the depression was there and they still had these symptoms, but they saw them differently. They experienced them differently. They were able to do other things that were meaningful to them in their life because of the insights they had during the psilocybin session, and that gave them a new appreciation for how they wanted to live. It connected them maybe in a new way to their values or their relationships that, despite the depression symptoms, kind of changed their life in other important ways, created a better quality of the life that they were living. 100% of the people in this study said it was one of the top 5 or single most psychologically insightful experiences of their entire life. And about half of them said it was one of the most psychologically challenging or spiritually significant experiences, but almost all of them said that it was one of the most personally meaningful experiences that they had ever had. And usually when people are rating these items, they're rating them like in the context of the birth of their children, the death or the loss of loved ones, these deep kind of ripple effect moments that people have in their life. So, which I think helps us understand that even if your depression doesn't go away, wow, this is still a very meaningful moment, and there's other things potentially to be learned. So getting back to this quantum change model, we looked at mystical and insight experiences, and we did see that there is a correlation between the intensity of those effects across the psilocybin sessions and a reduction in depression. So this helped to give us a little bit of clarity about whether our thinking about this combination of effects made sense. Interestingly, this correlation of insight was stronger than the correlation of mystical experiences, which was surprising to us because up to that point, the mystical experience had gotten all this attention in the research and in the media. And here we actually saw that the insight effects had a stronger connection to what was helpful for people. So I want to read, which reminds me, if I'm going to read it, I have to tell you what it is that I'm going to read. One of the things that we ask people to do the day of their psilocybin session is when they're getting ready to leave and their pickup person is coming to get them and they're heading out for the night, we ask them to write down their narrative experience. We ask them to write down, kind of just start to jot down notes. You can write it as a story. You can write it as bullet points. You can draw, and you can do whatever you want. But we want you to start to do something to write down what happened during the session. And they bring this report in the next day. We have them read it, and then we kind of start to use that as a foundation for the integration therapy. What were the meanings? What were the things that came out of the experience? How are you making sense of those, et cetera? So this is one of those reports. I brought in 2 reports from one person, the one from their first session and also the one from their second session. And this was a young male participant. It was actually the only participant in our study who had never had any treatment for depression before. It was also the youngest person in our study, and they were in their early 20s. And they had been depressed for quite a long time, although they didn't know that it was depression until they were getting a little bit older. But they had had a pretty extensive abuse history in their family. Their parents were divorced. And they, of course, were randomized to the delayed treatment condition. I just felt like everyone who was really struggling somehow was randomized to have to wait 8 more weeks. It was really, difficult for people. But they got through the 8 weeks, they got in the study, and this is the report that they wrote after the first, the lower dose psilocybin session. Shivering cold, the concept of time is lost. My body is rocking, rolling, and writhing with the music. On inhales, I'm soaring up a mountain in the clouds in unison with the crescendo. On exhales, my body and mind are slipping into a darkness and quiet that has no end to its depths. Other times, I feel the loud, turbulent, diffuse mix of thoughts, feelings, memories, anticipations, and the occasional moment of stillness. I felt an infinite series of expansions and contractions. I wanted to see and have ultimate realities revealed to me. I kept asking for answers, but I saw nothing. What I did receive was an internal, brief feeling of peace, of knowing and understanding without really knowing what I was understanding. It was acceptance. As I'm sitting here writing this, I thought the experience would have a deep, long-lasting impact on me, but I'm really worried that it didn't. I do not feel a strong emotional attachment to what happened. It seems fleeting and like it's going away. It's almost like it wasn't powerful enough to create a noticeable change in me. I don't feel like I learned something clear and concise for me to take away from it. Like it didn't make a powerful or lasting impression. I'm really disappointed in myself. I feel like if I was able to go deeper, perhaps things would be better. Maybe I'd be better. I felt like if I could have just seen or understood things more clearly, then maybe I could have gone deeper. So they came in to the next session, the next morning, really distraught and upset because they thought that they had done something wrong. They thought that somehow they were a limitation to getting better, and they were really worried that the treatment wasn't going to work for them. And so we talked about that. We decided to go forward into the higher dose the next session, and this is what they reported at the end of that session. The main theme was healing and letting go. Healing came in many forms and feelings. I felt as if pain and sadness and trauma and guilt were draining from my body, as if it were being washed away and cleansed. I felt guided and compelled to let go of hurtful memories and recognized it was time to let go and okay to move on from my past. I lost my place, hold on. There we are. I felt the music was playing an integral role in guiding where the healing needed to take place in my body, in my mind, and in my heart. I felt it flowing through my body as a bright silver light traveling where it needed to go and guiding my thoughts to tranquility and acceptance. I truly felt embraced and taken care of by some completely unnamed force. That force allowed me to be open and willing to dissolve and dissipate the depression that was stuck in my mind. It allowed me to trust in myself and to be comfortable opening my once closed and guarded heart. I had a profoundly clear understanding that everything was happening exactly as it needed to be, and everything will be okay no matter what. The first psilocybin session dramatically broke up and cracked and loosened all the stuck negative energy and rigid patterns of my mind. Once it was loosened and broken up, in the second session, I was able to clear all that once hardened debris free. Step 1, jackhammer my mind and soul and show me that I can survive that pain. Step 2, gently and lovingly cleanse everything out and allow myself to let go and heal. I felt such a strong sense of soft, glowing, healing light, assuring me that there was nothing to fear or feel sorrow for. I felt I was in the presence of a pure and perfect energy that was healing me. I never once felt fear during the second session. I knew I was going to be okay. I am okay. And for the first time in my life, I discovered the possibility of what it feels like to love myself. I've never felt that way my entire life. And I truly value this journey for showing me that I can honor myself and others as equals on a deep, soulful level. So not that we have to have data after a report like that, but this is their data. All of their measures of depression and anxiety and suicidal ideation and disability in functioning. And what you see, obviously, is a really dramatic drop across all of these measures that persisted up to a year later for this person. They basically were in complete remission from any mental health concerns. What was really fun for us was, this was one of the people that I worked with, and what was really fun for us is that at the end of that 12 months, they had gone back to school. They had realized there was this path that they were really interested in that they had never had the confidence to pursue. They had gone back to school for that. They had gone into a relationship that was like the first relationship for them, and it was just really exciting to see a lot of these positive developments in their life. We've now published the long-term effects from everybody in the study, and what you see on this graph is that basically the people who were in remission were still in remission up to a year later, and the overall effect was similarly about 2 to 4 times larger than other treatments. So I'm pretty quickly, just to make sure that I have time for some questions, going to talk about some of the findings that we haven't published yet. And these are from our neuroimaging analyses, as well as some of our other data analyses that we're trying to now dig into either what are some of the biological or other types of relational aspects of this treatment that might help us understand why it was successful for some people. So for our neuroimaging, people were put into an fMRI machine 1 week before the first psilocybin session and 1 week after the second psilocybin session. And what we were really interested in exploring was this part of the brain called the amygdala, which is the part of the brain that is responding to emotional information. It's kind of the emotional, center of experience. And for depressed people, the amygdala will respond very strongly to negative emotional information in the environment. So, if a depressed person sees someone on one side of the street that has a frown and someone on the other side of the street with a smile, their amygdala is going to light up and focus more on the person with the frown. So we were curious, well, does the amygdala change its reaction to this type of emotional information after psilocybin therapy? And what we found is that did happen with the sample, that the amygdala responded less to negative emotional information than it did prior to the treatment. And that change in the downregulation of the amygdala response was also correlated with less depression at follow-up. So this helped to at least start to understand what might be happening in the brain in these folks that could potentially explain why the treatment was helpful. We then started looking at the relationship qualities between the people in the study and their therapists, because obviously there's so much connection. We're spending so much time trying to create that safe environment, building that trust and rapport. So we were curious, what effect might that have on why people might be better? And what we found was that what was interesting is that we found that therapeutic alliance, that strength of the relationship, was self-reported by the patient or the volunteers as something that increased over the course of that psilocybin session. So from before the first one to after they were over, they felt like that strength of the bond and rapport were getting stronger. And they also, what we also found was that the degree to which they felt a strong sense of rapport and bond was moderately correlated, and in some cases highly correlated with depression at the outcomes. So it did seem to us like there was something really important about that relationship for the volunteers in the study. We also found here that the bonds that they were experiencing, this therapeutic alliance, was also correlated with the acute effects. So that the stronger the bond that was reported before psilocybin session was correlated with more intense mystical experiences and more intense insight experiences. So that relationship seemed to be important not only for what might happen during the session, but also what might be happening with their mental health after. So where does this leave us? Well, we do think that the mystical and insight effects seem to be related to a variety of things going on in the session, but we're also now seeing, obviously, that there are other biological and relational components that seem to be affecting people's mental health. And we think that this could start to explain some transdiagnostic mechanisms of action, that for a variety of different conditions and struggles that people might have, these experiences might be beneficial. Having a strong connection with a supportive provider and having these quantum change experiences could help people potentially with PTSD, with anxiety, in cancer patients dealing with existential distress, OCD. It's also been tested now among people with autism, spectrum disorders, looking at social anxiety, just across a range of different concerns, all with the same things that are emerging, showing that it might be helpful. We think that we're actually just getting down to a deeper level of what might be creating some of these dysfunctions in mental well-being to begin with. Not necessarily treating the autism spectrum disorder or the cancer or some of the environmental or structurally oppressive issues of our society, but helping people get to a deeper level of healing from different types of trauma that might be bringing about the depression, the anxiety, the substance use disorders. So we're exploring this now in a variety of trials for people with lots of different challenges. We've just launched the first trial at OSU with veterans with PTSD. We're also exploring trials to hopefully launch in the coming years with gender and sexual minority individuals, Spanish-speaking individuals, and my team is also very interested in adolescents and what will this look like after FDA approval for adolescents who also have an unmet treatment need in our culture. And so we're going to be hopefully exploring that in the years to come. I should have mentioned this at the very beginning, and I can't believe I didn't, but obviously I'm not the only one doing this work on this team. There's a lot of people, and they're not even all on the screen, but these are some of the folks that were critical people who guided these studies, who developed these studies. My mentor, Roland Griffiths, on the top left, has been pioneering this work for 25 years. And so I just feel really appreciative of being able to be in a community of people who, allow me to explore things that I'm interested in and who have provided me such amazing guidance and mentoring. So I wanted to point that out. And I'd be happy to answer some questions.
Right, thank you so much. We will now begin the question and answer portion of tonight's event. Because this event is being live streamed, please raise your hand and wait for a microphone to reach you before asking your question. Also, out of respect for both our limited time and other questions in the audience, please keep your questions brief and return the microphone after asking your question. We do reserve the first question for students, and after that point, anyone in the audience is welcome to ask a question. So at this point, we are looking for our first question.
So my question was, do you think the effects would have been so strong if the treatment wasn't also paired with the integration therapy afterwards?
I think that the treatment has not been explored as what we would call in a dismantling study, where we're kind of looking at which specific components were helpful. So it's hard to know whether the integration was critical or whether the preparation was critical. But what we do know is that all of these things together seem to be what contributed to the effect. But we don't really know, if we took out one piece, would it still work? What we do know from other types of studies of people using psychedelics in ceremonial, spiritual contexts, or using them on their own, out in the real world, that the people who report that they engage in some of these same things that we do in the studies, so some talking about it with a trusted person, going to people for help if they need it, having a guide or someone that they trusted who knew they were doing it in case they needed support, those same kinds of things that we do in the studies, that when we look at their experiences, we do see that they're also reporting less challenging experiences. So I do think that there's an importance there, but I think scientifically we don't know for sure that it's actually critical. Clinically, I think that for some, it was absolutely imperative because, people will leave these experiences with sometimes very little understanding of what it all means, what do I do with this? I was mentioning earlier today to some people that we had one person who felt like the entire time they had this giant metal squid living inside of them that was churning away their organs. I don't know how to make sense of that, neither did they. But it was important for us to talk about it and have time to try to, figure out how they were going to move forward with that in their life. So I do think it's probably important for people.
Thank you. Hi. Thank you so much, by the way. That was a really great talk. I was wondering what you think about how this will, if it takes more flight, how this will affect the psychiatric industry as well as other forms of medication such as SSRIs, et cetera. And also whether you think this could get to a place of being accessible on a wide scale of people.
Yeah. Difficult questions. What I can say for sure, that I know for sure, and there's a lot I don't know, what I can say for sure is that the FDA has signaled to the government that they're within about 18 to 24 months of approving MDMA for PTSD and psilocybin for depression. So assuming that they're accurate in their timeline, the Biden administration has created a federal task force to bring together all of the different governmental agencies that would have to oversee the dissemination of these treatments. The DEA would have to be part of that to change legislation. The Department of Health and Human Services would have to be part of that to determine if Medicare and Medicaid were going to pay for it, which of course has implications on whether other insurance companies would pay for it. And of course, there's issues around who is going to be able to do it, how are they going to get trained, what kinds of settings would need to be created to allow this kind of approach to happen. So there's quite a few issues that need to be figured out in the next, I guess, 18 months to know the answer to that question completely. My guess is that even if that timeline is accurate and we see them approved next year sometime, it's going to be a while before people are trained to know how to do this treatment. It's likely going to involve advanced licensure above and beyond what people are already trained in. So they're going to have to be in these programs. They're going to have to learn how to do this treatment. They're going to have to be in settings that are accredited, to do that, to be able to store psychedelics in that setting, et cetera. So it's going to be a while until it's widely accessible. But I do think that we'll see in places, that are more metropolitan areas, we probably will see it quicker because there's more infrastructure already in the major cities. But of course, that's only for people who have insurance or who have accessibility to current mental health care systems and feel safe in those environments. We have a lot to do about the structural issues around why our current system doesn't really work already. And I don't think just embedding this new thing in that current system without making these other changes is actually going to be that effective. So I think there's quite a bit that's going to have to take place before they're, potentially a first-line treatment or a replacement for antidepressants or other medications. But, for the people that are having the treatment, for those that are in remission, they did that with 2 doses of the drug. So, it could eventually, I think, get to the point where we do see a decrease in prescriptions of standard psychiatric medications. But I think it'll be probably a while.
Hi, Dr. Davis. I really wanted to say that I appreciate this talk. I, for one, don't really know a whole lot about this topic, but I'm really glad that I now do. I just had a question about kind of what the after effects of the treatment. I was curious if the patients who were in remission and just all the patients in general developed some sort of dependency on the psychedelics or the treatments afterwards, or if they just kind of had a desire to want to continue, or if it was just kind of they were satisfied with how the treatment went.
That's a great question. What we know from a variety of different studies is that psychedelics are among the most safe substances that exist in nature. We know that especially compared to highly addictive and destabilizing substances like sugar and caffeine and alcohol and tobacco, that psychedelics are rather benign physically. They don't typically create a dependent syndrome. They don't necessarily create other types of problems for most people. Now, that being said, psychologically, they can be very difficult and challenging, like we've talked about. And for some people, there is a psychological motivation to keep exploring what is in that psychedelic experience. And so they will be, for some people, motivated to seek these experiences out again, but not necessarily in the same way that someone who is physically dependent on a substance might seek that out for a different biological need. And so we know that that's broadly true. And so for this study, to answer your question specifically, we did not see nobody reported using psilocybin in the year that we asked them about it. Nobody sought psilocybin, with the one exception of the one person I mentioned who didn't have the second session and then asked us at 6 months, I think I'm ready for my second session. They were interested at that point, but they didn't do it at least before the end of the study. What was interesting too, I think clinically, to get to your other point about did they even want to, actually most people in the study said that they never wanted to do psilocybin again. And in part because for most of them, even the people who were not in remission, who might have had a therapeutic reason to do it, for a lot of them, the concern that they had about ever doing it again, at least not in a medical setting, which of course outside of research isn't possible in the US right now, they said that they couldn't ever picture doing it in a not supported, safe environment. And so the idea of just going and getting mushrooms was not appealing to them because they knew, in that setting, it was difficult for them. They might have had these traumatic realizations or these difficulties that they just didn't really feel like jumping into that again without the right kind of safety and support. So I don't think it's likely to produce, kind of what we would typically think of as an addictive, potential. Again, with the exception of people who might just for other psychological reasons want to do more of it to explore their own psychospiritual understanding or their own physical sense of themselves.
All right. Well, thank you. I'm sure others feel the same way, that this has been an interesting talk. I'm curious about what you use to measure depression and what symptoms may have responded more than others. Do you get any feedback on that? And was it the Hamilton scale that you used?
We used, yes, that's great. We used a version of the Hamilton scale called the Grid-HAM-D, which is basically a measure of depression across all different types of domains, but it's structured so that when a clinician is administering it, it provides a structure for scoring that is more reliable across multiple people who might be doing those depression ratings. But it probes into all of the different facets of depression, including the cognitive ones, things like thoughts of feeling guilty or feeling other types of cognitive issues. They might also, it also explores somatic complaints, sleep issues, weight loss, weight gain, irritability, all these different features. I think we have not yet done a deep dive to see whether there were differences in our study, but there's been another group of people over in London who have done that with their psilocybin depression trial that actually was a placebo-controlled trial, it was a controlled trial comparing an SSRI to psilocybin. So half of the people got an SSRI for, I think, 6 weeks, and half of them got 2 doses of psilocybin. And when they've looked at their data that way, they were seeing that there were kind of patterns emerging in some of the different symptoms that were responding. There seemed to be pretty big changes in some of the cognitive and emotional symptoms of depression, but relatively fewer changes or less smaller effect of changes in other areas like sleep and irritability. But one thing that was kind of curious is that when they looked at the different pattern was that those already were kind of like lower than these other bigger kind of seemingly clearly depression symptoms. And so they were curious about whether that was like a smaller change just because it started off smaller too. So I think there's a lot more to explore there, but it did seem like the big kind of things that people would probably know about themselves were depressed. Those were some of the bigger areas that changed in their study. Mm-hmm.
So thank you so much. So I think it's really fascinating about using it in a larger dose, a few amount of times for this long period of regression in depression. But I'm also interested about the usage of psychedelic substances when it, like microdosing, of using it frequently, or I guess more frequently than just twice, but in a much lower dose. And I'm also curious about the usage of other medications following these psychedelic experiences, like SSRIs, for whether that may be lingering depression, or whether SSRIs don't help with, for an individual, don't help with depression, but may help with something like anxiety. So that is what I'm curious about, and would love to hear what you have to say.
Sure. So to the first point about microdosing, there has been almost no research on the topic of microdosing. So it's really hard to know scientifically what's going on. There have been a few studies, and a couple published in the last year, that unfortunately was basically saying that it's likely a placebo effect, that there really weren't any discernible changes in a clinical trial setting on symptoms of depression or anxiety. What's important about that, I think, is that it's still very early in that research, and there's more studies that need to be done, I think, to know for sure. But also what I think is important is that placebo effects aren't necessarily a bad thing. We know that placebo effects, or just like you thinking that the medication is going to help you, is responsible for up to 30% of the effect of current medications that are on the market. And for those 30% of people, or 30% of the effect that they're feeling from that across the population, like that's great, they're feeling better. So, if microdosing is helpful and it's a placebo effect, then, I don't think that's necessarily a bad thing, but at least in the clinical trials so far, they're not showing that it's necessarily effective, as we would expect the macrodoses to be. However, that's a whole different question from, I think, the bigger population of people who are talking about the benefits of microdosing, who are actually talking about it from like not a mental health perspective, but from a enhancement of creativity, or or an enhancement of their ability to think through different problems in their profession new and in different ways. And so I think there might be some interesting questions about, whether microdosing actually helps to expand, one's well-being as opposed to necessarily maybe being a treatment for mental health. But also there are thousands of people out there writing up reports and talking about their experiences of microdosing that it is helpful for their mental health. So scientifically, I think the jury is still out, or maybe pointing towards I don't know, but there's a lot of people out there saying that it's helpful for them. So to the other question about medications after these experiences, I don't know that there's any contraindication that I can think of that I would say is a concern for people going back on medications after a psychedelic experience. However, for a variety of reasons, people might choose to either go back on a medication or not. But as long as that's under the care of a prescribing physician, then I don't think that I can think of any reason why they shouldn't go back on it if it's an important option for them and they feel like they want to do that. There's more of a concern about whether they're on the medication before or during the psychedelic. And so for people who are in that group, it's one of the reasons why they have to come off their medications to get into the clinical trials, is because there is potentially some contraindications there that we need to steer clear of in the clinical research setting.
Thank you. My question is, we know that we live in a society that has, in a culture, America, that has criminalized psychedelics for such a long time, and that has an effect on how people perceive them. Is there any thought into how, whether it's internally or externally, negative feelings towards psychedelics can affect people going into these treatments?
I don't know, but what comes to my mind is the fact that we know that what people think is going to happen to them under the effect of any substance has an effect on what actually happens. So I could imagine that the more stigma that one has lived with about their thoughts about psychedelics certainly could potentially impact the experience that they're having. It's one of the things that we actually address a little bit in the preparation phase of the treatment, is talking about their expectancies, talking about what they want from the experience and their intention for the experience. And we actually, if things like stigma, or usually it comes up in the form of questions or concerns about it, usually when we have those kinds of questions, we address them and talk through them in order to try to minimize that kind of impact. But I would imagine that, any of us, growing up in this culture who, had any exposure to the DARE program would certainly have a lot of opinions and potentially fear-mongering attitudes about what drugs are in general. So I think that absolutely could affect some people's experiences, especially when things start to get a little unusual, or, when people start to feel like a little bit of difference in their bodies and maybe experiencing a more flexible boundaries of their between them and things around them. That can be quite destabilizing if you've always been told that yep, that's a bad trip and this is why people shouldn't do psychedelics. Those kinds of thoughts can come up in the moment and create more paranoia and anxiety. So yeah, I think it's possible, but it's not something that we've empirically tested in the studies. Yeah.
We have time for one more question.
Do you think that the treatment would benefit minors or not because of brain development?
So it's going to be a really important phase of the research that once the FDA approves in adults, they actually will require the manufacturer of MDMA and psilocybin to study this in adolescents, so that if it can be found to be safe, that because there's such a large unmet need, that it would be available to adolescents. And then eventually they're also, if it's effective there, then they would kind of continue testing it in younger pediatric populations, which brings about a whole lot of really important questions about administering psychedelics to developing brains, and important questions about the risk-benefit analysis of someone who might be suffering with PTSD or depression or debilitating anxiety, and whether the benefit of potentially alleviating those symptoms is worth the potential risk that might be involved in neurodevelopment. I think that it's, I don't know, can I say that? I think based on some of the emerging research in adults, looking at actually the neurogenerative processes that unfold for psychedelics, things like making more neural networks more plastic and actually growing dendritic spines on the neuron and anti-inflammatory processes that are unfolding in the body, I have a feeling that it's maybe not likely to be dangerous, but obviously those studies will have to answer that question and be able to say whether or not it is safe or not. But what I am excited about is that right now the signals are pointing towards those studies will be done, and so we'll hopefully have an answer to that in the coming years. Yeah. Thank you so much, everyone. I'm happy to answer a couple of questions if people want to come up after.
Yeah, and that concludes tonight's program.
so
Once again, thank you so much, Dr. Davis.
Cheers.